Well, hello, and welcome to my case study on pediatric neurology. So this case study is about a 6-month-old baby who is being seen for a well baby check, but the parents have some complaints or some symptoms that they've been noticing. So we write this as parent complains of, or if it's an older child, patient complains of. So it's not like they're complaining. But the parents are complaining of symptoms of their baby being irritable, very lethargic lately, not feeding as well as the baby normally was, and occasionally vomiting. At the well baby visits, we always measure the length, the weight, and the head circumference. It's very important to measure how big the head is and how it's growing, more importantly. Is it staying on the same curve? Just like the height and the weight, we look and see the age of the child and then look and see the centimeters or inches and then measure it on the curve. As long as the baby's head is staying on a curve, some babies have smaller heads, some babies have larger heads, but as long as they're staying on that curve, that's usually expected. But what's happened with this baby is at 2 months, the baby's head circumference was 38 centimeters, which was at the 50th percentile, this dark black line. Then at 4 months, the baby's head size jumped up to 42 centimeters. So that put it up to the 75th percentile. And now at the 6-month visit, we're noticing that the baby's head circumference is 46 centimeters, which is over the 95th percentile. So it's kind of off the charts here. So when it's jumping percentiles like that, that is concerning. Coupled with the symptoms that the parents have noticed, this is cause for definite concern. On physical exam, the baby has a bulging anterior fontanelle, the soft spot right on the top in the front of the baby's head. The baby has a heart rate of 110, respiratory rate of 28. The baby is crying and difficult to console and is irritable. The RN completes the assessment following the nursing process, diagnoses this baby with there is something of concern here, neurologic concern for sure. So the RN then has a plan, and that is first to notify the provider. Neurology is consulted. Skull x-rays and a CAT scan have been ordered by the provider. What is noted is hydrocephalus, and that is, if you can see in this picture here, the infant on the left has a normal skull with ventricles, and the baby on the right has hydrocephalus. And that is an increase in cerebral spinal fluid, or CSF. So it's putting pressure on the brain and causing increased intracranial pressure, which is causing those symptoms. This fluid is not being able to be drained and is causing those symptoms. Now, what could be causing this? Well, sometimes babies are born with congenital hydrocephalus due to congenital problems, prematurity, bleeding on the brain, infection, so forth. Other babies have acquired hydrocephalus, which could be caused by neurologic malformations, most commonly what's called Chiari malformation. It could be an infection such as meningitis. It could be trauma, bleeding on the brain. So we're not sure what's going on with this infant at this point. Well, the baby was diagnosed with hydrocephalus, and The treatment for that depends on the cause. But for this baby, they determined that hydrocephalus was going to be a lifelong problem. So the baby was decided that the baby needed a ventricular peritoneal shunt, or VP shunt, as we call it. And what this is a surgical procedure where they put a little tube in the ventricle of the brain and drain it down into the peritoneum. And it is all inside. You can have a shunt, which is an external ventricular drainage device, but this baby had a VP shunt, which, because they determined that the baby would have hydrocephalus for life, they needed to do this VP shunt procedure, so it's all internal. So the assessment, we definitely need to be monitoring for signs and symptoms of increased intracranial pressure, which the baby was showing signs of when he arrived for his 6-month checkup. We need to monitor the neurologic status closely, level of consciousness, if there's seizure activity, motor development. We want to monitor the vital signs. Babies can have decreased heart rate, increased blood pressure. And if they're crying and irritable, they may have increased heart rate, increased respirations. We need to monitor for signs and symptoms of infection because the VP shunts can get infected. So after the baby has the surgery, the plan will be to keep the baby positioned flat on the non-operative side, monitor for level of consciousness. We will monitor what we call neuro checks. Often as soon as the baby comes out of surgery, and then gradually gets longer and longer in between neuro checks. Monitor intake and output. The baby will stay nothing by mouth, or NPO, until the bowel function returns. We will administer ordered antibiotics, again, because of the surgical procedure. We don't want an infection to happen because that catheter is right in the brain, and that's not a good place to have an infection. We're going to monitor for signs and symptoms of infection, such as fever. And we need to definitely educate the parents. Because the baby will go home with the shunt, we need to educate the parents on signs and symptoms of shunt malfunction or shunt infection. So what are the signs and symptoms of shunt malfunction? Shunt infection signs are elevated vital signs, poor feeding, vomiting, decreased responsiveness, seizures, or signs of local inflammation along the shunt tract. Signs of a shunt malfunction are similar: vomiting, drowsiness, headache, although we won't be able to monitor that in a 6-month-old, and signs and symptoms of increased intracranial pressure. Now, to remind you, the signs of increased intracranial pressure, early signs would be headache, vomiting, blurred vision, dizziness, increased blood pressure, pupil reaction time being decreased, sunsetting of the eyes, changes in level of consciousness, irritability, seizure, a bulging, tense fontanelle, and a high-pitched cry. If that increase in intracranial pressure is not noticed, late signs of increased intracranial pressure may occur, and that is lowered level of consciousness, decreased motor and sensory responses, bradycardia, irregular respirations like Shane Stokes respirations, decerebrate or decorticate posturing, and fixed and dilated pupils are definitely a late sign. Posturing, remember, there's decorticate posturing and decerebrate posturing. Decorticate posturing you can remember by pulling your arms up towards your core. Pulling your arms up towards the core of your body, the corticate. And decerebrate is the opposite. And decerebrate is the worst of the two types of posturing. So you can remember that by hearing decerebrate is not so great. Sunsetting of the eyes occurs with increased intracranial pressure at times. And you'll notice these whites of the tops of the eyes. So it makes the eyes look like a sunset. So this case study continues, and the child recovers from the surgery, goes home, and is doing fine. Child is now 3 years old, and the parent calls, again complaining the child is having a fever and irritability for 3 days. What is the priority of the RN? A. Administer acetaminophen to decrease the fever. B. Ask the parent why they waited 3 days to notify the provider. C. Ask the parent if the child has had vomiting or headache. And D. Instruct the parent to bring the child to the emergency department. Which one do you think would be a priority? What do you think is going on with the child? What are the concerns that the RN would have? You can pause this and decide which answer you think is best. What did you pick? That's right. The correct answer is D. This child is having signs and symptoms of increased intracranial pressure and shunt infection. This child needs to be seen immediately. If that shunt is infected, again, the brain could become infected, and that's very dangerous. So the child needs to be seen and evaluated immediately. Remember to always follow the nursing process in the questions such as this. Remember that you need to have enough assessment data in order to plan and implement. So in this question, do you have enough assessment data or do you need more assessment? Yes, you do have enough assessment data. A lot of nursing students may pick C because they remembered that asking the parent if the child has complains of a headache may be a sign of increased intracranial pressure and shunt malfunction, which is correct, but you don't have to continue to do the assessment. And many 3-year-olds are not going to complain of a headache. They just may be irritable and have a fever if they have an infection. They may not complain of a headache. So you don't want to keep on doing more and more assessment. As soon as you have enough, move on to implementation. Once this child reaches the emergency department, they do recognize that the child is having a shunt infection, and the child goes back to surgery to have the shunt replaced. Normally, children with BP shunts do have to have their shunt replaced as they age anyway, because they are getting taller and they will need a different size shunt. That's it. Bye-bye.